Okay, so I think we are ready. I'd like to thank Dr. Alexandra Mier for joining us, accepting our invitation. Dr. Mier is an ophthalmologist, retinal specialist on the Department of Ophthalmology of the Centre Hospitalier Intercommunal de Créteil in Paris, in France. And so she's going to talk about type 3 macular neovascularization and differentials. Thank you very much for accepting our invitation. If you want, you can start now. Thank you.
Thank you very much for your kind invitation. I'm very happy to be speaking today. I'm an associate professor of ophthalmology, and I've been working in retina and retinal imaging and on type 3 macular neovascularization for the last 10 years, I think. And I'm very happy to be speaking to you today about some quite a hard topic, I think, the origin of type 3 and the masqueraders, and of course, in between the diagnosis and the differential diagnosis. So let's start. These are my financial disclosures, but none is in relationship with this presentation. When we see patient X and patient Y, on the OCT, they both seem quite similar, I think. They both have drusen. Patient X seems to have some drusenoid PDs and some soft drusen, while patient Y seems to have hard drusen and some small soft drusen. But if we look at these two eyes, they are not at all the same, and they do not have the same prognosis, actually. I've already answered the questions in my slide. If we look at 1 year follow-up, things are quite stable. Patient X still has his drusenoid PDs and his soft drusen. Patient Y still has some soft drusen and some hard drusen. But at 2 years follow-up, patient X will develop type 3 macular neovascularization, while patient Y will be exactly the same. And if we look at 10 years follow-up, we can see then that things have changed dramatically because patient X has now a complete outer retinal and RP atrophy, while patient Y has only some drusenoid PDs and an epiretinal membrane. And no sign of neovascularization, by the way, or of atrophy. So if we look, for example, at 5 years follow-up, patient Y develops this epiretinal membrane. We can see some SDDs, we can see some drusenoid PDs, but if we look closely at the first OCT from patient X, he actually had subretinal drusenoid deposits, so reticular pseudodrusen, since baseline. And then he developed type 3 neovascularization. Of course, we know that SDDs are a risk factor for developing type 3 macular neovascularization with a very typical presentation on conventional angiography, as you can see here. And on autofluorescence, while at baseline, they both seemed quite the same, at 2 years follow-up and mostly at 10 years follow-up, you can see the enormous difference because patient X has developed an extensive macular atrophy, as you have seen on the OCT previously, while patient Y has only some reticular pseudodrusen that are there, but no atrophy in sight. So, of course, the type of druse is very important. And this is an article from Rick Spade, but there are many, many papers in literature which show the importance of the type of drusen for the prognosis to late AMD, either exudative or atrophic. And in the case of subretinal drusenoid deposits or reticular pseudodrusen, we know now that it is associated classically with both type 3 neovascularization, but also with the development of geographic atrophy. So obviously the type of drusen in the beginning is very important. And we will be speaking not only about SDDs and type 3, as you have seen earlier, but also about other types of drusen that may be associated with type 3 macular neovascularization. So you know all, I think, that in exudative AMD, Gas described, of course, type 1 and type 2 choroidal neovascularization, and then Januzzi and Bailey-Freund added to the initial classification from Gas type 3 choroidal or macular neovascularization that was supposed to be an intraretinal neovascularization, or as Don Gas suggested, a chororetinal anastomosis. So also a type of choroidal neovascularization. And things have been quite controversial regarding the origin of type 3 macular neovascularization. If we look on multimodal imaging, notably on OCT, we can see that there is a very classical intraretinal hyperreflective complex here with, of course, what we call subsidence, this downward deflection of the outer plexiform layer, some intraretinal fluid that is classically associated, a thin choroid, some reticular pseudodrusen, also a classic association, and in some cases, a soft drusen or a drusenoid PD. On multimodal imaging, in angiography, we can see that in fluorescein angiography, there is a focal hyperfluorescence that will gain some leakage in the late frames of the examination. And typically, in the late frames of the ICG angiography, there is a little hotspot. So this small hyperfluorescent lesion that corresponds to type 3 macular neovascularization. And of course, in some cases, we can also see hyperreflective foci. So if we perform, for instance, an OCT angiography for this patient, what we will see on the flow images corresponding to the outer retina is this tuft-shaped lesion that can be seen here with the yellow circle. But if we do a 3D rendering, we will see the vessels from the deep vascular complex that will drag down towards the outer retina to form this hyperreflective complex, as you can see very nicely here. So type 3 seems to originate on multimodal imaging for now from the deep vascular complex and is characterized by a progression towards the retinal pigment epithelium in the early stages of type 3 macular neovascularization. So let's see a little bit about the history of type 3 and its origin and why its origin seems to be right on imaging on the deep vascular complex. This is the first description by Hartnett in 1992 of this small anomalous complex that actually occurred at the end of vessels, sometimes associated with hemorrhage, as you can see here. And through time, this deep retinal vascular anomalous complex has had many, many names, from retinal angiomatous proliferation, retinal choroidal anastomosis, type 3 macular neovascularization, type 3 choroidal neovascularization, and different descriptions in multimodal imaging. And each new technique added something new to what physiopathological insights we have regarding type 3 macular neovascularization. And this has been quite a revelatory technique, has been OCT angiography, showing in a depth resolved fashion the different parts of type 3 macular neovascularization. But of course, imaging is not everything. Clinical pathologic correlations, even though they are difficult to obtain, are very, very important to know exactly what happens in the case of type 3 neovascularization. And in this article from Christine Curcio and her team, they have shown very nicely that in type 3 neovascularization, there are vascular elements of retinal origin with collagenous material and Mueller cell processes that will implant into the thick sub-RP basolaminar deposit, which may stimulate the appearance of this intraretinal complex. However, what is very important in this clinical pathologic study is that the chorocapillaries and very often the Bruch membrane is intact completely. So to the question, is the origin of type 3 neovascularization intraretinal or choroidal? Both clinical pathologic correlations and high-resolution multimodal imaging show that intraretinal precursors of type 3 neovascularization are essentially intraretinal in the deep vascular complex, or in the deep capillary plexus. This has led to an updated staging system for type 3 macular neovascularization, as you can see here from this article from David Saraf and Daniel Su, in which precursors located into the DVC will progress through different stages towards the outer retina and implant into the sub-RP space into thick basolaminar deposits. What is very interesting in the study from Daniel Su and David Saraf is that hyperreflective foci have been known as precursors of type 3 neovascularization in almost 78% of cases. So in the enormous majority of cases, we have these hyperreflective foci as precursors of type 3 neovascularization. So this has led to a new nomenclature for reporting neovascular AMD, and we now call type 3 macular neovascularization. We now call what we called previously choroidal neovascularization as macular neovascularization in order to correctly incorporate type 3 neovascularization into this classification. And this is a case of one of the first patients I think I've seen with OCT angiography. She's a 93-year-old woman with decreased visual acuity in the left eye, 20/50, and metamorphopsia. You can see that she has a lot of drusen, and at the border of the foveal vascular zone on fluorescein angiography, there's this hyperfluorescent small lesion that corresponds to a hotspot, to a hyperfluorescent punctiform lesion in the late frames of Indosian and green angiography. So when passing a scan of OCT through this lesion, we can very nicely see that it corresponds to a hyperreflective intraretinal complex associated with some hyperreflective foci, but also with some intraretinal fluid. And when performing OCT angiography, interestingly, in the deep capillary plexus, we see here some very small high flow vessels that will go downwards towards the outer retinal layer, towards the avascular layer, if you want, and form a tuft-shaped lesion that we can see here. However, within the choroid capillaries, there is no correspondence to this initial lesion that we see on the avascular layer. And when we look very closely to the corresponding B scan with flow overlay, what we can see is that actually the flow stays above the Bruch membrane. It does not go within the choroid capillaries. So that's why we don't see any correspondence within the choroid capillaries. And this has been shown in many, many papers from our group and from other groups that in type 3 lesions, actually in most cases, there is no chorioretinal anastomosis, but a retinal anastomosis. So no definitive retinal choroidal anastomosis seen on OCT angiography. This is another example where we can very nicely see the presence of this tuft-shaped lesion within the outer retinal segmentation with no correspondence within the choroid capillaries. And again, if we look at flow, here there is some flow projection, as you can see, but the flow stays above the Bruch membrane. Another thing we have to keep in mind, I think, regarding type 3 macular neovascularization is that OCT angiography may be able to discern not only type 3 and to diagnose, but to discern also precursor lesions incorporating flow, such as the case for nation type 3 macular neovascularization, which corresponds actually to this intraretinal hyperreflective foci we have seen on OCT images. And about hyperreflective foci, this is a very extensive subject. And as you all know, hyperreflective foci have different significations in different retinal diseases. But in the specific case of age-related macular degeneration, they may suggest either a progression from intermediate AMD to geographic atrophy in the context of serous or calcified drusen or pseudodrusen, but also may signal incipient type 3 neovascularization. And what are these hyperreflective foci per se? When we look at the histology, and this is another paper from Christine Curcio, these are actually RP cells that will migrate intra or subretinally. And sometimes they may be even conglomerates of hyperreflective foci. So in some cases, we have a drusenoid PD, and we see these small hyperreflective foci that have flow on OCT angiography, as you can see here, and those foci within time will get closer and closer to the apex of the drusenoid PD. And at some point, they will just unite with the apex of the drusenoid PD, and somehow exudation will arise. And this has been described by my colleague and friend Riccardo Sacconi several years ago as nation type 3 neovascularization. Here you can very nicely see, for instance, we have this small hyperreflective foci that we can see even on the unfast flow image from OCT angiography. We can ask ourselves, is this pigment? Is this really a vascular component, a variation type 3, or is it just a migration of RP cells as we have seen previously? So this has been described as the preclinical stage of nation type 3. These are hyperreflective foci that have flow, as opposed to the enormous majority of hyperreflective foci that do not have flow on OCT angiography. But there is no contact with the RP in this preclinical stage. However, the patient has to be followed up. And if we are patient enough and see the patient in several months, here is the image at 3 months follow-up, but it may be more or less, we can see that actually the patient did develop a small exudation and a hyperreflective intraretinal complex suggestive of clinically active type 3 macular neovascularization. And here you can see the flow overlay. We see that the flow goes through the hyperreflective foci under the sub-RP space, and there is some intraretinal fluid on both sides, and this is also visible on OCT angiography. And of course, we performed for confirmation classical angiography, which shows a hyperfluorescent lesion at the border of the foveolar vascular zone with leakage in the late frames, as you can see here, and with a small hotspot on late ICG-A. If we look at rotational three-dimensional OCT angiography, we can very nicely also distinguish between nation type 3 and clinically active type 3, because we can very clearly see that here nation type 3 is really above the retinal pigment epithelium, while the clinically active type 3 will invade the space below the RPE. As you can see here, it goes downwards. And of course, the prognosis is not the same when the lesions are clinically active. In nation type 3 macular neovascularization, we have either a progression towards early type 3, so the patient has to be followed up quite regularly, or we might have a regression without functional impairment. So multimodal imaging in these patients is really essential. We have to perform a close follow-up and early treatment when the lesion becomes clinically active. Another thing about type 3 macular neovascularization is that sometimes we have these sub-RP hyperreflective lines that have been quite recently described at the onset of type 3 macular neovascularization, and that may correspond to either regressive drusen or onion sign and are associated with a worse clinical outcome. And this is the paper I published with Professor Suede and Giuseppe Kerkes several years ago, when we first saw this small sign. So we have patients with regressive calcific drusen. As you can see nicely here, there is a hyperreflective line within this drusen. But in 1 year, we still have the calcific regressive drusen, but we also have a type 3 macular neovascularization that has risen above this regressive calcific drusen. And if we look on multimodal imaging, what we can see besides this sub-RP multilaminar hyperreflectivity is that we actually see in ICG angiography not 1 but 3 type 3 lesions, 1, 2, 3. I think you see my mouse arrow. And in late ICG, there are 1, 2, 3 hotspots. So this is a case where we do not only do we have a type 3 on a regressive calcific drusen, but we also have multiple type 3 lesions. And these lesions may be also seen as tuft-shaped lesions on OCT angiography within the outer retinal segmentation. So we have 1, 2, 3 lesions. And of course, this is also visible within with the corresponding flow. This is another example. So early frame of ICGA, late frame of ICGA, can very nicely see that in the late frames there are multiple hotspots. And when performing OCT angiography, there are 1, 2, 3 lesions in this patient, and there is corresponding flow on the B scan within this intraretinal complex corresponding to multiple type 3 lesions. In all cases, as you can see here, there are sub-RP multilaminar there is sub-RP hyperreflectivity corresponding to regressive calcific drusen. This is another case. So here we can very clearly see from the beginning that we have a typical type 3 neovascularization, right? We have a small hyperfluorescent lesion at the border of the foveolar vascular zone, only one in the early frames of ICGA. In the late frames of ICGA, there is this typical hotspot corresponding to this type 3 macular neovascularization. This is an 82-year-old male, best-corrected visual acuity 20/50, so quite okay. So let's see on the OCT. Oh, on the OCT, the image is quite surprising because we can see that we have a hyperreflective intraretinal complex, so corresponding to a type 3 macular neovascularization with intraretinal fluid. But to our great surprise, we also have some sub-RP hyperreflective hyperreflective lines in the sub-RP space, in the PD, that look a lot like what has been described as an onion sign. And I think you all know the onion sign described by Mukamala and Bailey Freund, more than 10 years ago, with these layered hyperreflective bands that were believed to suggest chronic exudation in some patients. And actually, when performing histological studies on patients with onion sign, they did see that the onion sign corresponded to precipitated cholesterol crystals underneath the retinal pigment epithelium. So if we look at our patient with an onion sign and the type 3 neovascularization above the onion sign, what we can see throughout time is that he will clearly develop sub-RP neovascularization. Here he had a macular hematoma, and in the final stages, after almost 10 years of follow-up, he did develop a very important fibrotic lesion, fibroatrophic lesion. But if we look at his OCT angiography, we can very nicely see that despite the extensive fibroatrophic lesion, there is a macular neovascularization, which seems type 1 macular neovascularization underneath, within the fibrotic lesion. And the circle, I think, is gray. The small corresponding type 3 neovascularization that led to everything that was in the beginning here in the inferior part of the mixed type 3, type 1 neovascularization. Here's another example. So this case is strikingly similar to the other one, right? We have an intraretinal hyperreflective complex corresponding to type 3, some intraretinal fluid, and an onion sign with sub-RP hyperreflective multilaminar lines. And here is a zoomed image. You can see a little bit better. 1 year after treatment, the patient developed sub-RP fibrosis, and we can still see these hyperreflective lines, as you can see here with the arrow. So I wondered actually if the characteristics of type 3 macular neovascularization with sub-RP multilaminar hyperreflectivity were different with regards to classical type 3 macular neovascularization. What I learned about type 3 with sub-RP multilaminar hyperreflectivity was that there were no significant changes in BCVA after anti-VEGF treatment at 1 year, so no gain in visual acuity, with a significant increase of macular atrophy, significant decrease of choroidal thickness in these patients, and about 76%, 77% had regressive drusen at baseline versus more than 90% at 1 year follow-up. When comparing the sub-RP multilaminar hyperreflectivity to classical type 3, there was no difference in age or in number of intravitreal injections on the 1 year follow-up we performed in this study, but there was a very important difference in staging at the onset of type 3 macular neovascularization. Because for patients who had these sub-RP hyperreflective lines, stage 1 of type 3 macular neovascularization was found in like 60% of patients versus 44% of classical early type 3. So patients who have sub-RP hyperreflective lines tend to have later staging at the onset of type 3, and a very great difference in the number of lesions. So multiple lesions in the sub-RP multilaminar hyperreflectivity group versus unique lesions in the classical type 3 group. And of course, when we have multiple type 3 lesions, we have multiple chances of generating exudation, no? And of course, the association with regressive drusen was significant for the group with sub-RP multilaminar hyperreflectivity. So we now know that when we see a regressive calcific drusen or an onion sign, we must think that in some cases, these patients may develop type 3 macular neovascularization with worse clinical outcomes, that they need a close follow-up and early treatment when the lesion becomes clinically active. Because we have a tendency, or I have a tendency when I see patients with regressive calcific drusen to say, I'll see the patient again in, 6 months, because they only have atrophy. So when there are regressive calcific drusen, we must think also of type 3 and see the patient more regularly and explain what are the emergency signs. And last but not least, the common masqueraders of type 3 macular neovascularization. And here I want to talk about two lesions that look a lot alike, and again, the terminology is quite controversial, and we will see. The first one is PVAC. So PVAC has been described as perifoveal exudative vascular anomalous complex by Giuseppe Kerkes and Suyed in 2011. And what characterizes PVAC is that there is this large isolated perifoveal anomalous aneurysmal change, as you can see here, sometimes accompanied by exudation. I say sometimes because it has been proven by Riccardo Sacconi later on that PVAC does not always have exudation. That's why I put the E between in between brackets. And this PVAC lesion appears in patients with no relevant personal or familial medical history. So in patients that are otherwise healthy, we don't know many things about the prevalence, the pathogenesis, the course or treatment. There are a few articles on some series of PVAC of 15, 16 patients, but nothing larger than that. And the classical aspect on OCT is that they have this aneurysmal aspect with round hyperreflective walls and hyperreflective, usually hyperreflective inner part, and they are accompanied sometimes by intraretinal cystic spaces. When we perform, however, fluorescein angiography and ICG, there is no sign of neovascularization. And this is another example of PVAC from an article of Salomon Cohen and Saram Rejen, in which you can very nicely see what OCT angiography can bring to the detection of this perifoveal exudative vascular anomalous complex. And you can see that here in the deep capillary plexus, we have this high flow lesion corresponding to the aneurysmal PVAC lesion that we can very nicely see on OCT. This is another example of several cases, and this will show you that PVAC cannot only be seen in the deep capillary plexus, as we have seen earlier, but also in the superficial capillary plexus, such as in case 1. In case 2, PVAC is seen only in the deep capillary plexus. It is completely undistinguishable in the superficial capillary plexus, while in case 3, it is visible in both the superficial capillary plexus and in the deep capillary plexus. So there are various locations of PVAC on OCT angiography. Only the superficial, only the deep, or both of them. What about treatment? So in the treatment of exudation secondary to PVAC is not established. Do we do only monitoring? Do we perform some anti-VEGF injections? If the patient does not respond to anti-VEGF injections, could we perform focal thermal laser, for example, knowing that the lesion is really perifoveal and we risk a paracentral scotoma in our patients? So we tried, I think, all three options. Normally, we monitor patients. We did perform anti-VEGF therapy if the patient had exudation and was willing to do the injections. And this is actually quite a nice case that we published with a patient that completely, where the PVAC completely regressed with the fluid also after 3 intravitreal injections. And this is his 5-year follow-up, and you can see that the PVAC is really occluded at 5 years follow-up, and there is no more fluid since the first 3 injections. Unfortunately, not all cases progress this way, and sometimes we do focal thermal laser if the patient does not respond to anti-VEGF, but the risk-benefit ratio has to be chosen very, very carefully in these cases. Of course, PVAC is not the same as other perifoveal retinal vascular abnormalities. So when we think of differential diagnosis for PVAC, we must think of type 3 macular neovascularization, right? But as we have seen, there is no sign of neovascularization on OCTA, on FA, on ICGA. Then we might have some perifoveal microvascular changes like microaneurysms or telcaps in diabetic maculopathy. But patients with PVAC normally aren't diabetic, or even in retinal venous occlusion sequelae. We might have vascular abnormalities in inflammatory diseases, but patients with PVAC should not have signs of general or local inflammation. And another differential diagnosis is macular telangiectasia type 1, which we know affects mostly young patients, male, and typically features multiple capillary, venular, and arterial aneurysms. And this is an example of type 1 macular type 1 macular telangiectasia, where we can see on fluorescein angiography very nicely that there are multiple aneurysms, and there is some macular edema with something that looks a lot like PVAC on the OCT. This is another example. So we can very nicely see the presence of telangiectasia on 360 degrees in this patient, with very important leakage in the late frames, with some aneurysmal changes, but they are not isolated as we are used to see in PVAC. And on OCT angiography, both in the superficial and in the deep capillary plexus, we see these telangiectatic capillaries more prominently in the deep capillary plexus compared to the superficial capillary plexus. However, what we know about PVAC is that in the series that have been published, PVAC were diagnosed in patients with diabetes or with hypertension, but both patients, diabetic and hypertensive, did not have any signs of associated retinopathy. So no signs of microaneurysms, for example, in the context of diabetic retinopathy and so on. PVAC has also been described in age-related macular degeneration by Riccardo Sacconi, and in cases of epiretinal membrane in the series from Sarah Mrejan and myopic macular degeneration. But this may be also coincidental findings because we have so few cases finally. So when we think about type 3 masqueraders, we should think, of course, about microvascular abnormalities with aneurysmal manifestation, right? Such as PVAC, for instance, where we can see flow in the superficial and deep capillary plexus, or both of them. The only problem is that less than 2 years ago, a new type of lesion has been described, which looks a lot like PVAC, but it comes apparently only from the deep vascular complex, which is DRAMA. DRAMA is the acronym from deep retinal edge-related microvascular anomalies. And we can see this small aneurysmal change that looks a lot like PVAC again, located in the deep capillary plexus and sometimes associated with exudation. Now, what is interesting, and this is a very zoomed, maybe too zoomed image of a drama. You can very nicely see that you have these hyperreflective walls on OCT with a hyperreflective content. So it really looks a lot like what we are used to see as PVAC. And its isolated and unilateral nature is also quite similar. And here you see that it is visible uniquely into the deep capillary plexus, as you can see in this patient. In this patient, there is a corresponding flow also on the corresponding B scan, as you can see here, here, or here. And these are multiple examples of drama. However, interestingly, when a patient with drama is followed up during time, there is no progression towards type 3 macular neovascularization on long-term follow-up in the cases published until now. However, intraretinal fluid accumulation and leakage seem, in this context, not to be exclusively related to the presence of neovascularization, because here we have intraretinal fluid, but no neovascularization theoretically. And we now know that we may have non-neovascular age-related macular degeneration with exudation. This has been described. All types of fluid and non-neovascular AMD have been recently described. So maybe intraretinal fluid corresponding to drama can enter this vast space of exudative non-neovascular AMD. But to complicate things even further, drama can actually be associated to type 3 macular neovascularization, so appear in the same eyes as type 3 MNV. And this is a case study from Christine Corsio's team and Andreas Berlin, which very nicely shows a patient which has had bilateral type 3 macular neovascularization and has had both type 3 macular neovascularization with the green arrows, but also drama lesions with the yellow and pink arrows. And if we look, for instance, at his left eye, we can see on OCT that there is small type 3 neovascularization developing here. But when looking at the images in postmortem, what becomes very clear is that the complex, you see here, the complex will extend from the inner nuclear layer towards the OPL, Henle fiber layer, and ONL, and will terminate implanted in the basal laminar deposits on the calcified drusen. But the Bruch membrane is completely intact. However, in the same eye, if we look at the drama lesion, what we will see is that while we have minimal leakage as opposed to type 3 on fluorescein angiography, when we look at the histological pictures here in the lower panels, there is a vessel extending downward from the inner nuclear layer into the OPL above the drusen, but will not go and implantate itself in the basal laminar deposits. And there are also several differentiating factors histologically. I mean, how often do we perform histology for our type 3 patients in order to know if they have one or the other? So there has been some controversy regarding the difference between PVAC and drama and the whole spectrum of microvascular abnormalities that may accompany type 3 macular neovascularization in particular and in general. And I suggest that these are very nice papers talking about these microvascular abnormalities. However, I think what is important to retain here is that concerning the common masqueraders such as PVAC and drama, type 3 may coexist with vascular formations that are candidate precursors, early stagers, and masqueraders for type 3. So we must pay attention because sometimes we may have a type 3 macular neovascularization and several scans above or or underneath, we may have also drama lesion in the same patient. And this is very important to know. So in the end, I think the communication of the neovascular complex with the RP and the sub-RP space from the deep capillary plexus seems necessary in order to develop what we call an active form of type 2 macular neovascularization, which has exudative signs and which we will treat by anti-VEGF. And with advanced imaging, I think even if we have advanced imaging, actually things are not as simple as we thought, because when we have advanced imaging and access, for instance, to multimodal imaging, conventional angiography, OCT angiography, we will detect earlier stages, we will perform closer follow-up, which will help us to detect minimal changes, but minimal changes we will not be sure of if these are really exudative changes or not. We will detect subclinical entities such as nation type 3, for instance, other microvascular abnormalities such as drama or PVAC or non-exudative PVAC, and all these lesions have a different prognosis. So it's very important to think about all these questions, and actually with more imaging and more clinical pathologic correlations, we have more insights into the physiopathogenic complex, the physiopathogenic sequence in type 3, but also we have more and more questions about what's really happening and how one type of lesion can progress towards another. And I'd like to thank you for your attention and to thank my friends and colleagues with whom I've worked a lot on this subject. And if you have any questions, of course, I'll be happy to try to answer.
Rodrigo, posso falar agora?
Okay. Thank you very much, Dr. Mier, for this concise and enlightening talk. Dr. Michel is the head of the Retina department. He would like to say something, and we have already 2 questions from Renato and Marina that I would like them to ask by themselves.
Of course.
Bonjour, Alexandre. C'est très
Bonjour.
bon de vous voir de nouveau ici avec notre universitaire. Welcome, bienvenue. One question I would have for you is, Rodrigo already said that was a wonderful lecture, so thank you so much. What would be the treatment, or if there is any treatment that is indicated when you don't find any neovascularization, for example, in the PVAC lesions or similar ones, that you recommend any kind of treatment? And I would also, although it's not the subject of your talk or your lecture, I would like to know the experience that you are having in Europe regarding the
photobiomodulation.
I think we lost. It's a photobiomodulation. Yes.
Yeah, I think it's photobiomodulation also. So maybe I'll try to answer the first question the time that the connection is reestablished. So I think that for PVAC lesions, we don't actually have a consensus here, but neither in literature, there's no consensus. So everybody tries to do their best. In most PVAC lesions, when there is a little bit of exudation, I tend to monitor patients. And if there is increasing exudation, I will try usually anti-VEGF. If anti-VEGF do not work, either I will try to monitor. Very seldomly, I think there are 1 or 2 patients that I have seen where I actually performed focal thermal laser, but I know that there are other teams here in Paris that are more prone to performing focal laser in these patients with PVAC. I've been quite afraid to generate scotoma in patients that otherwise have a good visual acuity, and very little exudation. So this is for PVAC. I think mostly I monitor, and if there is increasing exudation, I will try to some anti-VEGF injections. How about you? What do you do in Brazil when you see PVAC lesions? Do you
Somebody
do
would like to
anti-VEGF
answer?
or?
Yeah, sometimes try anti-VEGF, but we know that doesn't work very well. I've never tried laser. I don't know if any of my fellow colleagues have tried micropulse or something else, but I don't have experience. Dr. Lavinsky, do you have experience with photo coagulation of PVAC lesions? Dr. Eduardo Cunha, Casella, I don't know.
I tried. It doesn't respond very well. So tried endpoint management, Pascal. It did decrease a little bit, but I had one case that I recently tried faricimab, Vabysmo, and it responded very well. I'm not sure if it's just the switch of the class of the anti-VEGF, but it was a case that I tried. I've been using Eylea, aflibercept for 3 years with no good response, and I've tried like the second injection of faricimab. It's really dry and no edema. So maybe faricimab is an option with this kind of vascular diseases. No?
I didn't try faricimab, but yeah, why not? It's a very good idea to try it. And maybe in terms of laser, Navilas would be an idea because it's navigated laser, so we can block the foveal region and make sure that we will not hurt precious foveal tissue.
But depending on the patient, they will draw for you every spot that you burn. So
yeah.
So if it's less, it's not an engineer. It doesn't matter to do focal. But I had some patients that they could draw every place that we did a focal laser. So it's should be careful to do visible laser.
Yeah, it's complicated. I agree.
Eduardo, go ahead.
Yeah, I'd like to say something. Alexandra, thank you very much. I have an article which is going to be published, I believe, in the European Journal with Kerkes, with Giuseppe Kerkes and someone. It's a resident from France. I have sent to him a case 1 year ago, exactly like he described it. I remember that 41-year-old patient, very healthy, with a classic PVAC lesion. And I've sent to Kerkes, and he says, let's publish this case. It's going to be published with someone from France, a resident from your place. I don't know. But the only thing is that I don't believe Kerkes agrees with the idea of PVAC not coming from the deep capillary plexus first. And secondly, his idea, because my patient responded nicely with 2 injections of Eylea. And in Kerkes' idea, Eylea is okay because of the, what's the name? The placenta or something, the PDGIF, which comes with the... Yeah, and he says that this is very important in some cases. Now, classically, PVAC does not respond, but this article is going to be published, I believe this year. And his idea, he believes that some cases will respond well with Eylea. So just one case, but I believe in PVAC because this case is, you're going to see, if you have the chance to see, I would like to hear.
Of course, look for it.
Another question about your cases. What about bilaterality? You didn't mention the other eye.
About type 3 in type 3?
Yes, type 3.
Type 3 is classically bilateral. It's asymmetrical. It appears, the other eye is affected classically after some time, not in the same time, but it's true. I didn't mention the whole epidemiologic context. But yeah, so most cases in the series I've presented or in the cases I've presented, patients had bilateral lesions in the enormous majority and were mostly female as described in literature. So,
and the youngest patient that you have been examining, which
with type 3, I think more than 70 years old, around 70, but mostly 80, 90 patients in France. I don't know, patients are very, very old sometimes when they have the diagnosis. But with PVAC, however, in literature, the mean age in the series published is around 60, 68 years old, so a lot younger than patients with type 3.
Thank you.
I have a question.
Marina has a question, and afterwards, Kaya, please.
Marina.
Bonjour.
Bonjour.
Je vous remercie pour votre disponibilité et votre attention. Je m'appelle Marina, je suis en les première année de spécialisation en rétine dans la Unifesp. Et je pense que je vais poser la question en anglais.
Dans le chat?
Oui. Est-ce qu'il y a un type de préférence d'anti-VEGF ou un plan thérapeutique comme Mencel, Prorenata, Treat and Extend?
So, very good question. I'll answer in English just in case somebody doesn't speak French here. So, typically we say that type 3 is associated with a thin choroid, right? And typically we also say that Eylea will have more impact on the choroid compared to Lucentis. However, in literature, there is no difference in terms of visual gain or other morphological characteristics when using one anti-VEGF or the other. I do not have any information on brolucizumab, for instance, or on faricimab with type 3 macular neovascularization, but between Eylea and Lucentis, there are no differences in literature beyond what we say in an informal fashion. And as for the protocol, given that it is a type of lesion that is prone to the development of macular atrophy, I think that PRN is the most adapted regimen of treatment. So treating the patient only when exudation is present, because with treat and extend and monthly treatment, we risk to over-treat the patient, so to stimulate even further the development of atrophy, I think.
Yeah,
What do you
thank
think?
you,
I don't know. How do you treat type 3? Do you treat it with treat and extend like other types of neovascularization, or mostly with PRN? Or
I usually treat with PRN, worrying about this choroidal atrophy. I try not to use treat and extend. I don't know.
Yeah, same here.
Minimize the anti-VEGF load, so you can. I don't know if it's going to work, but try to avoid the choroidal atrophy in the long-term treatment. Michelle had a question about photobiomodulation. I think he's back.
Yes. Yes. Sorry, I started with the first question and then I forgot. So photobiomodulation, we have used it in reticular pseudodrusen, for instance. Not very good results. With drusenoid PDs, very good results, but slight outer retinal atrophy that seems to appear. And honestly, I never tried it in my patients with type 3 macular neovascularization. Did you try it in? I remember that in Belo Horizonte, I think Andrea Romano showed me very nice cases of refractive exudative AMD treated with PBM in addition to anti-VEGF that tended to respond better after PBM. But I never tried it myself. What about you?
I think we are still learning, and there is a lot to know about in the future. But your experience with drusen, soft drusen, and drusenoid attachment has been good as far.
Yeah, really amazing, morphologically amazing resorption of the drusenoid PD. Visual acuity, good, but not an enormous amelioration, but it didn't drop or anything. It was quite stable. However, I think we have to have a little bit of follow-up to see if some kind of heavier form of atrophy will develop afterwards. That's what I'm afraid of. But for now, actually, there's only a little bit of outer retinal atrophy, so hopefully things will stay stable.
And your standard of care for now, for a while, has been to repeat every 4 or 6 months, or depends on the first result if you go ahead or not?
It depends on the first result. Actually, we do not perform PBM for all DRUS patients now. We have tried in the last 2 years to select patients in order to have a little bit of homogeneous cohort and to see what happens. We are currently writing a research protocol with different intervals for the treatment and for the follow-up to see if one arm responds better than the other. So for now, I don't have any definitive answer.
Okay.
But I think that it's a work in progress, and it's quite, I don't know. I'm quite happy that finally we have something to actually propose to patients with intermediate AMD for whom we said until now that, okay, things will evolve, but we cannot do anything for you. Take some, I don't know.
Yeah. Thank you for...
Caio,
Thank you. Thank you very much for your talk. It was amazing. In 2011, I described with Jay Tucker RP migration into the retina. And we saw that when there is a change on the forms of the RP migration, there is a new vascularization at that time. At that time, it didn't have any OCT angiography, so we didn't see any perfusion. Nowadays, if you see a perfusion on the hyperreflective foci, do you treat this patient or you do something different?
If there is just perfusion, but no intraretinal fluid.
Yes, no fluid.
If there's no fluid, I do not treat, but I follow up closely.
Monthly?
It depends if the foci is far from the peak of the PD. I will see maybe the patient in 2 months or 3 months, but I will explain when he has to come right away if, for example, he has a scotoma or metamorphopsia, etc. And if the hyperreflective foci with flow is really glued to the peak of the drusenoid PD, I will probably see the patient in 2 weeks or a month in order to see if it progressed towards minimal exudation and I should treat him.
And how often do you see neovascularization formation in those patients?
Sincerely, most of the nation type 3 neovascularization I have seen progressed towards early type 3. I know that in his paper, Ricardo said that in some cases it may regress spontaneously. I, for one, have seen it, I think, really several times, but in a minority of cases compared to the enormous majority of cases where after a delta time, which may be 2 months, 3 months, 6 months, the patient will finish by developing exudation. So for me, in the enormous majority of cases, it's like, I think it's like with non-exudative asymptomatic neovascularization, with quiescent neovascularization. It is there, it will be there for 1 year, 2 years, 6 years. At some point, with a rate of between 10 and 20% a year, the patients will develop exudation. It's really a minority of cases that will stay non-exudative. But this is a tendency. More VEGF is secreted probably when there is this connection. So I think exudation is inevitable in these cases. But it is my opinion. I don't have any I don't have any publications to back me up. For now, we don't know, but this is my clinical feeling.
Thank you. Just because Kyle asked about hyperreflective foci, did you have the opportunity to do any scans with the high resolution Heidelberg new OCT?
No.
Because they say that you can differentiate them, the hyperreflective foci, if it's a vessel or RPE. Usually the vessel has two hyperreflective points and the RP only one.
Only one.
Yeah, and you can see that in the B scan, and that in diagnosis if you don't have angial CT. So.
Yeah, unfortunately, I didn't have the chance to try the new high resolution spectralis, but yeah, that would be really, really interesting. And mostly when we read the articles from Christine Curcio, she describes several types of hyperreflective foci, the RP plume and the slowed type. And it's really fascinating. I mean, OCT is considered a sort of optical biopsy, but we're really far away until seeing all these details with non-invasive imaging. But at some point, I think now.
Rodrigo, can I ask you another thing?
And Luis Lima also has a question afterwards then.
I would like to ask Alexandra, have you seen cases that was described in France? IMAP, enlarged macular atrophy and something.
Extensive macular atrophy with pseudodrusen, yes.
Did you know that we have more than 100 cases in Brazil?
Oh, really?
I would say more. And in our place, Dr. Huang, if she's in the meeting, there is almost 100% of relationship with the rheumatic fever prophylaxis in the past. And all the patients, they come completely normal until 40 or 50-year-olds. And then they started most of the time complaining of night vision. And 100% of the cases, I don't know why, they mention treatment in the past for years to prevent rheumatic fever. And I had the chance to talk with someone from Italy, and he said that in 2 or 3 cases, the history was positive for patients originally from Italy. What do you have to say about, please?
No, this is very, very interesting. I didn't know that you had so many cases of EMAP. The association with rheumatic fever, I mean, was there in Brazil some kind of public health system in which patients received the prophylaxis systematically at age?
And that's why these patients today, they are about 60-year-old. It's not, we call here benzetacil. I don't know the name. We use the same antibiotic, penicillin.
No, how is it? It's penicillin.
Yes, but I'm not making a relationship with the disease. They don't have cardiac problems most of the time. They don't have chorea. What they say is, doctor, I have received for let's say 10 to 20 years prophylaxis with the antibiotic intramuscular, and then they come with this kind of a history. It's very it's very sad to see, because you cannot do anything. That is why I'm trying to use the photo. How do you call the biophotoimmodulator something? I'm going to try to use for some cases.
Yeah, to see if it works. But it's very interesting. It's penicillin, the drug that was administered for so long, for 10, 20 years.
Yes.
Benzathine penicillin.
Sorry.
It's benzathine.
Benzathine penicillin.
Yes.
It would be nice if you could. How often you see cases with the IMAP in your place?
We have, I think, a series of about 50, 60 cases. We recently published a paper on how to distinguish GA from IMAP using deep learning, but I should look on in the files of patients we included in that study and see if somehow there was some history of
Rheumatic fever.
Medication, or rheumatic fever. It's very interesting. Maybe there's some kind of toxicity involved.
Actually, Alexander, these patients they presented with streptococcus in the throat, and they used to treat before the disease appears, because the disease is not, it's very serious in terms of cardiac valve destruction, but they don't develop the disease. I don't know why they develop MUP, and then in 1 or 2 years they get blind in terms of central vision. It's very sad.
With all the classical features, the
yes,
peripheral degenerations, the presence of reticular pseudodrusen and everything.
Yes.
It's very, very interesting. I have no clue, honestly, but it's really, really, there is. Is there something?
Help us ask your patients, please. Help us asking.
Yeah, I will look into the files and see if we have something similar. Maybe if you can leave me your email address in the chat, I will copy it and email you if I find anything or if I don't find anything. But
because I am sure rheumatic fever existed in Italy 20 or 30
yeah, it should have existed in France also.
Of course, yeah.
I think.
Thank you.
No worries. It's really, really interesting. I really like retinal toxicity, so it's a subject that interests me very much.
Luis Lima, do you have a question?
Yes, thank you, Alexandra, for your talk. Excellent talk. I have a question regarding to the hyperreflective foci. Do you know if there is a relationship between the amount of this foci and the probability to the patient develop macular atrophy? I mean, the difference between a single hyperreflective foci and multiple hyperreflective foci?
This is a very good question. I think that I don't know if there's some description in literature. I know that there are plenty of articles which describe hyperreflective foci as risk factors for developing atrophy, but to my knowledge, I do not know if someone actually quantified the number or the area, the total area on OCT of hyperreflective foci and correlated it to the probability of developing or the time to develop GA. I think intuitively, you would think, that if a patient has 2 hyperreflective foci, it's less likely than if he has, I don't know, 20 hyperreflective foci. But what do you think? What's your experience?
Yeah, I think the same. I was asking because probably if there is a great amount of hyperreflective foci, the probability to develop the macular atrophy is greater than if you have just 1 or 2 hyperreflective foci in that area. So, but I don't know. I didn't make a search in the literature.
This is a very interesting study idea, actually. I think.
Yeah. This is a study idea, actually. Yeah.
And it's even easy to quantify. You can quantify them manually, or you can apply some segmentation technique. You can very easily segment on OCT hyperreflective foci and correlate with, if you have follow-up, you do a retrospective study, 20, 30 eyes. I think it's very, very interesting, and it's worth knowing.
Yeah, we can take a look at this. Thank you very much.
So do we have any other question? If not, I'd like once again to thank you very much for this excellent talk and giving us your time to share your experience with those diseases. We now usually have a clinical case that the residents and fellows present. If you would like to join us, we are more than welcome. But we know that you have a busy schedule, so feel free to leave if you need. And hopefully we would like to ask you another time to come back and enlighten us with your knowledge. Thank you.
Thank you very much for the invitation. It's been great to see you all again since Belo Horizonte, when I saw Rodrigo and Michelle. And I can stay, I think. I still have a half an hour for the cases, and then I have to disconnect because I have another meeting. But it's been really great to see you all. Sorry, I wasn't able to answer all your questions, but I think this is also part of why we do what we do, in order to answer questions that that we have regarding retinal diseases. So it just keeps things more interesting, not knowing all the answers. So,
Merci beaucoup. À bientôt.
merci.
Alguém tem um
Sim.
caso clínico?
O Pedro vai apresentar o caso dele do Grand Round da segunda-feira.
Tá, joia.
Bom dia, professores, conectando aqui.
O caso é em inglês, ou Pedro?
É em português, professor. Estão conseguindo ver minha tela?
Tá dando. Não sei se quiser falar em inglês, apresentar em inglês, mesmo com slide em português, daí.
Ok. Certo. Good morning, everyone. My name is Pedro Franco. I'm a second-year resident. Thank you for your lecture, Dr. Mier. I'll try to, unfortunately, the slides are in Portuguese, but I'll try to improvise in English.
Don't worry, Portuguese is okay. If there are images, I think.
Okay. Just, I'm
Just,
sorry if I speak a little bit slow.
no, you can speak in Portuguese. I mean, I will look at the slides. Don't worry. Just,
Okay.
You know that Alexander is originally from Romania, and Portuguese and Romance have some words in common.
yeah. I
Okay.
think I can understand the main idea. So just speak in Portuguese and
Okay. Okay, I'll speak in Portuguese then. Thank you, Dr. Yeah. Ok. Então, bom dia a todos. Eu vou apresentar o nosso Grand Round na segunda-feira, agora, dia 26, é o Grand Round do setor de retina, orientado pelo Dr. Lucas Zago, o nosso chefe do setor, então, Dr. Caio. Bom, temos um paciente de 70 anos, do sexo masculino, aposentado, natural e procedente de São Paulo, que buscou a nossa clínica com uma queixa de baixa visual em olho esquerdo. Ele tinha essa história há 3 dias, era uma perda visual aguda, indolor, sem trauma associado, não progressiva. De antecedentes patológicos, ele era hipertenso, dislipidêmico e ex-tabagista, não tinha antecedentes familiares dignos de nota. Ele tinha uma história já de não enxergar, não ter uma boa visão no olho direito, desde um trauma na infância, foi um trauma contuso, ele não sabe referir exatamente o que foi feito, ele não recebeu nenhum tipo de cirurgia na ocasião, mas acabou ficando com a visão prejudicada nesse olho. Ele fazia uso de hidroclorotiazida e losartana. A acuidade visual com pinholho do olho direito era de 20/200, no olho esquerdo 20/70. Lembrando então que o olho direito era o olho que ele já tinha uma perda visual prévia. Não tinha alteração de reflexos, fotomotor e consensual, não tinha defeito pupilar aferente relativo. A biomicroscopia anterior sem alterações, não tinha reação de câmara anterior ou células no vítreo, era fásico. A pressão intraocular era de 12 milímetros de mercúrio no olho direito e 11 milímetros de mercúrio no olho esquerdo. E eu vou mostrar fotos, então, da fundoscopia do paciente. Bom, então temos a retinografia do olho direito, lembrando que foi o olho que ele teve o trauma, um disco óptico róseo bem delimitado, uma escavação fisiológica, os vasos sem alterações, e ele tinha uma área extensa de atrofia, né, até onde podemos ver na retinografia de aproximadamente 10 diâmetros de papila, se estendendo desde a região da artéria temporal superior até a mácula, com mobilização de pigmento, podendo corresponder, então, a uma cicatriz prévia diante dessa história, e a retina aplicada. E no olho esquerdo, um disco óptico rosa, com margens menos nítidas, a escavação fisiológica, e percebemos diversos pontos de obstrução à passagem sanguínea, desde a emergência da artéria central da retina e seus ramos proximais, e uma palidez difusa da retina, poupando apenas o setor inferior à mácula, incluindo a fóvea, um território que pode corresponder, então, ao território da irrigação da artéria cílio-retiniana. Aqui, a mesma retinografia, é, já com composite, né, ampliando um pouco a nossa visão. E aqui, com um zoom, podemos ver bem os êmbolos citados, né, que podem corresponder a placas de aterosclerose, né? Vemos também a presença de um vaso fantasma não perfundido temporal ao disco, certo? Opa. E diante desses achados, a nossa principal hipótese foi de oclusão de artéria central da retina, de etiologia embólica, certo? E uma artéria cílio-retiniana patente. Lembrando que a artéria cílio-retiniana emerge a partir das artérias ciliares posteriores curtas, que são ramos da artéria oftálmica, fazendo parte, então, da circulação da coro capilar, presente até 20% dos pacientes. Bom, diante desses achados, dessas hipóteses diagnósticas, concluímos que o mais urgente era uma avaliação multidisciplinar, excluir riscos de eventos cardio ou cerebrovasculares, então contatamos a equipe de neurologia e cardiologia para avaliação do paciente. Julgamos necessário também excluir uma doença autoimune, como arterite de células gigantes. Solicitamos exames complementares, como ultrassom Doppler de carótidas, eletrocardiograma, ecocardiograma, VHS, PCR, hemograma, coagulograma, perfil lipídico, glicemia de jejum, uma eletroforese de hemoglobina para descartar qualquer alteração hematológica importante e o FAN e fator reumatoide. Solicitamos exames, então, particulares para avaliação, exames específicos do nosso campo, da oftalmologia, para quantificar melhor a perda visual do paciente, avaliar a retina do paciente, com tomografia de coerência óptica, a OCT angiography, a angiofluorescenografia, microperimetria. E aí tem também a discussão, nós tivemos essa discussão na apresentação do paciente sobre as chamadas medidas heróicas ou intervenções no momento ali da apresentação, como, por exemplo, massagem, com uma lente de 3 espelhos, o uso de hipotensores oculares ou paracentese de câmara anterior, de modo a tentar mobilizar esse êmbolo, ou até uma embolectomia IAG laser. A gente sabe que no Kansky, ele dá uma janela até de um dia para ser feita alguma medida como essa. Já na coletânea do CBO, eles escrevem até 90 minutos. É bastante controverso sobre a real eficácia desses métodos. Foi optado, o paciente já tinha uma história de 3 dias, foi optado por não adotar nenhuma dessas medidas nesse momento. Bom, então, avaliando a tomografia de coerência óptica do paciente, nós vemos uma interface vítreo-retiniana sem alterações, a hialoide parcialmente aderida, e um aumento da espessura de camadas internas e externas da retina, com hiperrefletividade da retina interna, um quadro bastante compatível com essa oclusão que nós citamos. E no CT angiógrafo podemos ver bem a correlação entre a retinografia e o exame angiográfico, evidenciando mesmo a diferença de perfusão entre a área perfundida pela artéria cílio-retiniana em todos os plexos, né, com a área de bloqueio na área perfundida pela artéria central da retina. Aqui na microperimetria, percebemos uma redução difusa da sensibilidade na região macular, praticamente todos os pontos testados. E na avaliação sistêmica do paciente, então, ele não tinha alteração de VHS, PCR, foi excluída a princípio a hipótese de uma doença autoimune, uma doença inflamatória, o FAN e o fator reumatoide não reagentes, sem alterações no hemograma, coagulograma e glicemia de jejum, a eletroforese de hemoglobina dentro da normalidade, e ele tinha uma alteração bastante marcada de perfil lipídico, um aumento de colesterol total e LDL, com redução de HDL, né? Um padrão bastante característico com síndrome metabólica e aterosclerose sistêmica. No ultrassom Doppler de carótidas, ele apresentava uma estenose carotídea menor do que 50%, não era uma estenose crítica, mas tinha um certo grau de estenose carotídea. Um ecocardiograma dentro da normalidade, não foi visto nenhum tipo de êmbolo para pensar num cardioembolismo, mas o paciente tinha extrasístoles ventriculares frequentes na eletrocardiografia e ele foi avaliado pela cardiologia na ocasião. Bom, como conduta posterior a esses achados de exame, ele foi encaminhado à cardiologia ambulatorialmente, após avaliação multidisciplinar de urgência para investigação e início da terapia antiagregante e lipemiante, até para investigação de uma possível arritmia também. E ele manterá segmento oftalmológico regular no setor de retina da instituição. Ele manteve esse segmento conosco. Ele retornou conosco após 6 meses. Nós vemos, então, na retinografia do follow-up, um disco óptico pálido, né, uma atenuação vascular difusa e a presença de vasos fantasma, justamente naquela região em que vimos uma hipoperfusão mais acentuada no local dos êmbolos mesmo. E no OCT do follow-up ainda vemos um certo grau de desorganização das camadas internas da retina, mas uma redução da espessura macular, né, comparado com o exame prévio. Aqui na angiografia fluorescênica, o paciente já apresentava um certo atraso no enchimento arterial, mas já com um certo grau de reperfusão, né? E nas fases mais tardias, ele apresentava um extravasamento na periferia temporal superior, ali superior, né, compatível com quebra da barreira. Esse foi um caso que... e perdão, talvez o mais importante para ser citado, o paciente possui uma acuidade visual final de 20/25, né? Então, visto que ele teve um quadro retiniano bastante grave, mas com essa poupança vascular da artéria ciliretiniana que realmente conseguiu preservar a sua visão central e permanecer com uma acuidade visual final bastante, muito boa. Como take-home messages, então, que podemos absorver, aprender com o caso, né? Vemos que a oclusão de artéria central da retina é uma emergência, né? Nós devemos considerar esse quadro como algo que deve ser abordado de maneira breve, mas principalmente na questão de investigação e avaliação sistêmica, né? Existem evidências robustas sustentando o encaminhamento para uma avaliação imediata quanto ao risco de doenças cerebrovasculares. Se você está num centro com pouco recurso ou sem a disponibilidade de avaliação de um especialista em neurologia ou cardiologia, é recomendado encaminhar o paciente para um centro de stroke, né? Como descrito na literatura, um centro especializado em AVC. Ainda não há tratamento específico baseado em evidências capaz de melhorar a acuidade visual final nos pacientes acometidos, sendo que em alguma das medidas heróicas que comentamos, existe inclusive a possibilidade de pior associado a eles. Em casos de artéria ciliorretiniana patente, como vimos nesse caso, é possível observar uma acuidade visual final preservada ou pouco alterada em até 80% dos casos. Então, realmente, é algo muito importante, é uma sorte mesmo que o paciente teve. E, por fim, que devemos encarar as oclusões de artérias retinianas como oportunidades para tomada de ação quanto à melhora da saúde cardiovascular do paciente, em conjunto com uma equipe multidisciplinar, né? Então, se ele ainda não tem acompanhamento com cardiologista, com médico de família, com clínico geral, considerar esse momento como uma oportunidade para encaminhá-lo para esses especialistas e, quem sabe, prevenir a longo prazo consequências ainda maiores, não só para a visão desse paciente, mas para a vida dele, né? Como infarto, AVC e essas doenças que são as doenças que mais matam hoje em dia, certo? Então, gostaria de agradecer a todos e convidá-los ao CIMASP, que vai ser logo aí, dia 20 a 23 de março. Muito obrigado.
Então, muito do caso lindamente ilustrado, né? Eu acho que vai ser perfeito para o Grand Round mesmo. Um detalhe acho que vale a pena citar, que apesar de ser muito raro, é justamente o oposto disso, né? É quando você tem a oclusão da artéria cílio-retiniana e o restante não, né? Então,
Perfeito.
aquilo que parecia ser, digamos, entre aspas, sorte, virou o oposto, né? Você tem justamente uma lesão que pega bem a fóvea em geral, né? Depende da irrigação, tem muitas variáveis também nesse tipo de irrigação de artéria cílio-retiniana, mas em geral ela vai para a fóvea, não é sempre, mas em geral vai. Então,
Perfeito.
esse oposto pode acontecer. Eu mesmo, em toda a minha vida, nunca tive êxito em nenhum tipo de tratamento para oclusão de artéria, para êmbolo, nunca tive para recuperação da retina propriamente dita. Como você falou muito bem, eu já vi endoftalmite por paracentese nessa situação, feita no consultório, né, pela urgência e tudo mais, mas já vi endoftalmite ocorrer também como complicação dessas manobras, como você falou, heróicas. Mas se alguém teve aqui êxito em algum tipo de tratamento, outro tipo de tratamento também que é preconizado, a câmara hiperbárica, mas se alguém teve algum tipo de êxito em algum desses tratamentos, por favor, se manifeste para a gente aprender aqui.
Excelente, Pedro. Acho que ficou bem ilustrado. Acho que não tem nada para a gente mudar. O tempo está bom. Então, Alexander, it's a presentation that we do. We have every Monday. We have a meeting that we call Grand Round with the whole the ophthalmology department and all the residents and other ophthalmology departments from Brazil. So this is a case that Pedro is presenting to us here because he's going to present next Monday.
So he's
And
training for.
yes, exactly. And he see if there is any change that he need to do before he's presenting on the meeting. And usually you get some retina cases that was not like a mystery case, but a case from daily clinical practice. So if you have any comments that you do different on this case of arterial occlusion, and
I think it was an excellent case, very, very nicely presented and with great imaging. I mean, you did everything and beyond, it was perfect. And with a very interesting discussion also about the follow-up of the patient and the general context of the emergency, what the patient has to do despite the visual acuity. Well, your patient was very lucky because 2025 after an artery occlusion is quite the exception, but he had a very nice ciliaretinal artery, which was still perfused. But in general, the fact that he has to take care of his cardiovascular health because it's like an opportunity to save the life of the patient, if not the vision, I think, in most cases. It was very, very, very nicely presented for me. No particular comments.
Thank you.
outros casos.
Tem mais algum caso?
Eu tenho aqui, professor. Vou compartilhar a tela.
Já.
Estão conseguindo ver direitinho a minha tela?
Sim.
Então, eu sou o Daniel de Boa, residente do primeiro ano. Vou apresentar um caso clínico da reunião de hoje. Então, nós temos uma paciente de 53 anos, branca, natural e procedente de São Paulo, com queixa de metamorfopsia no olho esquerdo há 20 dias. Ela negava traumas, negava doenças oculares, cirurgias prévias e referia ao uso de óculos de -4 dioptrias esféricas em ambos os olhos, nega comorbidades, nega antecedentes familiares e nega uso de medicações. A visão do olho direito era 20/40 e no olho esquerdo 20/80, pressão intraocular de 19 milímetros de mercúrio no olho direito e 20 milímetros de mercúrio no olho esquerdo. A biomicroscopia anterior de ambos os olhos era sem alterações, cílios e pálpebras sem alterações, conjuntiva clara, córnea transparente, a câmara anterior formada sem reação de câmara anterior, miristrófica e fáscica. A fundoscopia eu vou mostrar fotos. Então, a retinografia do olho direito é possível observar um disco óptico róseo, bem delimitado, escavação fisiológica, vasos de mácula sem alterações e retina colada. E a retinografia do olho esquerdo, um disco óptico róseo, bem delimitado, escavação fisiológica, uma lesão amarelada na região macular com hemorragias adjacentes e presença de algumas regiões de atrofia cororetiniana inferior ao disco óptico e na arcada temporal inferior. E a retina também era colada. Gostaria de abrir para as hipóteses diagnósticas. Posso seguir, professor?
Acho que pode colocar as imagens, as outras imagens. Ou se alguém quiser fazer algum comentário.
Marina, in
Oi,
French,
professor.
please. In French.
Ah, em frente? É, é, nous avons un patient de 4 de myopie et une lésion dans les rétinographies qui est pareil comme une membrane. Je ne sais pas comme je peux parler en français, like
Just speak in English or
membrane.
in Portuguese, it's
In
okay.
English.
Yeah, there was a nice fundus tessellation on both eyes, and there was some atrophy, right, in the fovea in the left eye.
And the left eye, we have a lesion,
Yeah,
a yellowish
some
lesion,
yellowish lesion.
que pareil, né? It's like a neovascular membrane of a myopia patient, and this atrophic lesion in the inferior temporal arch here. I think it's a neovascular membrane of a myopic patient that usually is a type 2 and which has a great response to anti-VEGF treatment, but we have to exclude another diseases. I think it was a female patient, right, Daniel?
Yes.
And exclude some inflammatory diseases like peak,
CMF. Yeah.
CMF, right? And the angiofluoresceinography would be necessary for exclude this diagnosis.
Então, seguir em português aqui. A gente precisa pensar em algumas etiologias, como citado pela Marina, coroidopatia punctata interna, PIC, retinopatia serosa central, membrana neovascular do alto míope e também, extrapolando um pouco mais, tumor de coroide. Seguindo com os exames complementares, a paciente foi submetida a um ACT do olho direito, que não mostrava alterações, exceto por essa convexidade aumentada na região macular. É possível observar também que essa convexidade ela era possível ser observada em diversos cortes, tanto horizontal, oblíquo e na vertical. E no ACT do olho esquerdo, a gente consegue observar a interface sem alterações, um edema macular cistoide entremeado com uma lesão de média hiperrefletividade e um material hiperrefletivo subretiniano, aparentemente entre a retina neurosensorial e o EPR. Aqui nos cortes radiais também é possível observar essa convexidade aumentada na área macular, um pouco mais pronunciada no corte vertical em relação ao horizontal. Foi submetida também à autofluorescinografia do olho direito, que não demonstrava alterações. E no olho esquerdo, uma região de hipoautofluorescência superior à fóvea com halo hiperautofluorescente.
Eu acho que não Desculpa, acho que não é autofluor, é
This is
sem...
infrared, yeah.
Infrared.
Verdade. Eu acho que eu acabei botando errado aqui, perdão. Eu vou passar aqui, tá? Para angioflúor. Então, na angioflúor do olho direito, também não apresentava alterações, conforme é possível observar nas fases posteriores do exame. E na angiofluorescinografia do olho esquerdo, é possível observar ao redor da região de atrofia na arcada temporal inferior um defeito, um extravasamento que vai aumentando durante o exame e um defeito em janela, possível ver já nas fases iniciais do exame. E na área macular, uma hiperfluorescência que aumenta também durante as fases do exame, com um padrão petaloide, sugestivo de membrana neovascular tipo 2. O paciente foi submetido a um ACT angiógrafo também, no olho direito sem nenhuma alteração, e no olho esquerdo demonstrando essa membrana neovascular tipo 2. Então, gostaria de abrir para as condutas.
Então, na angiografia, acho que tem um padrão de edema cistoide na mácula, né? Você não consegue ver vazamento, tipo uma membrana clássica, ou não. Só pegou, tipo, o edema cistoide, né? No ACT você consegue ver a trama melhor, né? Então, essa lesão periférica atrófica, né? Porque eu acho que tem relação com o quadro de aqui inferior à papila parece ser fora da arcada. Então, por classificação, você poderia associar com o MFC e não com pique, né? Mas eu acho que é uma membrana inflamatória, não relacionada à alta miopia, né? E agora tem essa relação entre pique em paciente mesmo alto míope, com miopia degenerativa, que acaba levando à atrofia patch atrophy. Então, a origem dessas patch atrophies no alto míope, na miopia degenerativa, que não é o caso aqui, que ele tinha 4, também está relacionado com membrana inflamatória.
How myopic was the patient? Sorry.
Pedro, você
For
tem
diopter.
autofluor?
Or,
4, minus 4.
diopter. Yeah.
Yeah.
A gente
Daniel, go back to the OPT.
Didn't understand.
Go back to the OCT.
Minus 4, but he does have a tilted disc on both eyes.
But the choroidal thickness
With the
is
choroid,
okay.
quite normal choroid,
Yeah.
yeah.
And, go to the left eye.
Yeah, the choroid is quite... And here, yeah, there is a type 2 and a lot of cystic spaces that may explain the petaloid aspect on fluorescein. So, did you categorize it? Was it a woman or a male?
Woman.
Woman. So, this is
52.
another argument in favor of inflammatory etiology, but there are no other lesions that might suggest, besides the lesion on the inferior arcade, that might be related to anterior inflammation.
There were not any lesions. Only this one.
Pedro, você tem autofluor ou você lembra o que tinha na autofluor, não?
Tinha só essa, professora. Não acabei colocando essa enganado. Tô achando que era, me confundi.
Uhum. E nesses casos, né, autofluor seria importante aqui quando há uma membrana neovascular em paciente jovem, né? Porque mesmo quando você tem uma membrana e autofluor não mostra lesão nenhuma, com o tempo esse paciente ele pode desenvolver alterações típicas de pique, né, ou de coroidite multifocal. Então, nesse caso aqui, importantíssimo, né, se ele não fez, pedir autofluor.
O paciente foi tratado?
Não, ainda não, professor.
Você mostrou um caso semelhante, parecido. Foi você que mostrou a semana passada, não?
Foi, acredito que sim.
Era uma outra lesão parecida, só que mais fibrótica, né? Mais antiga.
Isso. E esse caso a gente quis trazer hoje por conta desse aspecto da mácula, pensando em dome-shaped macula, mas,
Não acho.
enfim, era mais para ilustrar isso também. Por isso os cortes radiais em ambos os OCTs.
Was the patient treated by anti-VEGF?
No, not yet.
And did you do a, I don't know, an inflammation checkup, a general checkup to see if
Yes, everything was normal.
But I think the main hypothesis here is CNV,
yeah.
inflammatory CNV. I think that also this hyperreflective material we see more often on inflammatory CNV.
Yeah, there is a little bit too much exudation for a myopic CNV, in my
Yes.
opinion. Myopic CNV are more subtle, even when exudating. Here it's very important, and there is a tilted disc and some fundus tessellation, but nothing really. The patient has -4, not a lot of risk factors for. And do you do, by the way, sorry for the question, but do you do 3 anti-VEGF injections in these cases, monthly loading dose, or only 1 and see how it responds, how the patient responds?
Usually, I treat monthly and see if the patient responds.
Mhm.
But I've done 3 in a row as well. I think it doesn't matter if you see the patient every month and re-inject. They usually
Yeah, of
end
course. You see
with
the
the
patient
drug.
every month. Yeah, very nice.
Só para mais uma coisa, Rodrigo, rapidinho, assim, nesse momento aqui, assim, eu não vejo, né? Pelo menos os exames eles não mostram nenhuma lesão típica de coralite multifocal, pique ou alguma outra doença inflamatória, né? Então, assim, eu classificaria no momento esse paciente ele teria uma neovascularização de coroide idiopática, né?
Ô, Luiz,
No
mas você
futuro ele pode desenvolver,
Luiz,
aí classificaria como inflamatório.
eu entendi, mas você pode ter como primeira manifestação em pique, né, sem outras lesões, e ele tem essa atrofia, esse patch atrophy que tem ali embaixo. Tem uns trabalhos do grupo do Japão, da Ono Matsui, que ela está chamando atenção justamente por isso. Mesmo em miopia degenerativa, esses patch atrophies que aparecem, eles são originários de doenças de membranas inflamatórias e não a clássica CNV do míope que a gente vê em Lacker-Cracker. E ela sugere até imunossupressão nesses automíopes em miopia degenerativa para conter essas atrofias. Então, eu diria que essa atrofia pode estar relacionada com essa lesão central, uma lesão antiga. Tá bom. Alguém gostaria de fazer mais algum comentário? Ótimo. Obrigado, Daniel. Caio, você tem algum recado? Muito obrigado a
No.
todos. Então, acho que com isso a gente encerra a reunião, né? Lembrar, então, que a semana que vem vai ser uma reunião híbrida no departamento e online, né? E vai ter uma aula sobre endoftalmite. Acho que é isso. Thank you once again, Alexandra, for your kind lecture and great
Thank you
talk.
very much. Beautiful cases. I really like the discussion. I'm sorry I will have to disconnect. I was just typing the message. Thank you
Thank you
all.
very much.
And if you want to collaborate at some time, I think you all have my email, and I'll be happy to look further into the problem of rheumatoid fever and EMAP. It's really, really interesting. And thank you very much for the invitation. It was great.
Bye-bye.
Bye.
Ok. Tchau, tchau.
Tchau, pessoal. Obrigado aí todos, hein?